Telangana state. No, it will pick up, but still the burden is so much and the number received, I told last year it is 0.4%. To make it 50%, we have to go a long way, and I am not sure the only third party payment should go up. That's one thing. And the government, their spending is more on preventive medicine and communicable diseases. Only of late, the importance is being given non-communicable diseases, more so in neurology by the ISMR, even for grants of research grants also. So that is the state we are having it.
Interesting observation to share. It actually doesn't talk about what's happening in South Asia, but talks about people from South Asian origin in United States. And we actually did a study looking at what has happened in the United States in terms of stroke incidence in various ethnicities that exist. So essentially we looked at people who actually have origin from India and Pakistan and compared them to people who are African American, Hispanics, and the classic white people. And in the last 10 years in the United States, the incidence of stroke has gone down in all the categories except one category where it actually has increased. And that's actually the people who originate from India and Pakistan living in the United States. So somehow, for reasons that we don't understand well, perhaps actually the cardiovascular risk factors are becoming more prevalent in this particular group of people residing in the United States. And subsequently, we are seeing an inverse relationship in terms of actually paradoxical increase, while every other population in the United States is actually experiencing a decrease in the stroke incidence. So it's an observation, and I do not know the exact reasons, but it does actually.
Is Dr. T.S. Srinath Kumar, who is the president of the Society of Emergency Medicine India. He's also a member, Special Advisory Board, and also the DNB Board for Emergency Medicine in India. He's also a board member of the Asian Society for Emergency Medicine. He was an assistant professor, Department of Accident, Emergency, and Critical Care in the Vinayaka Missions in Salem, Tamil Nadu. Currently, he is the head and the group coordinator, Department of Emergency Medicine, Narayana Health, or Narayana Hrudayalaya in Bangalore. So I welcome Dr. Srinath Kumar to share a little bit about the emergency systems here in India and maybe extrapolate, the deficiencies or the goals and also the opportunities to improve in providing emergency care services in acute stroke. With that, I welcome Dr. Srinath Kumar.
Good afternoon, everybody. I thank the organizers for giving me an opportunity to speak in this forum. See, a lot of young faces, especially the emergency physicians, are also sitting here. Maybe around 15, 20 of them are here. Some of them are my students also. So, time is brain. That's what is for an emergency physician. And each and every time when you receive a call, a patient coming for stroke or activated for an EMS on stroke. So our system has been developed a lot, not like before. So what is the role of an emergency physician and pre-hospital care management in managing a patient of acute ischemic stroke? That's what the topic given to me. So definitions, since morning it has been going on, I need not say again. So 3 parts I would like to cover. One is the pre-hospital care part, wherein somebody activates a stroke, what you are supposed to do, and in the emergency department, what we have developed a module and which has been successfully run with our neurologist colleague who is also sitting here, Dr. Vikram. And emergency physician's care in the emergency department, what you are supposed to do. It doesn't end in the emergency department alone, because finally the patient has to go either to the critical care unit or to the operation theater to take up for the neurosurgeon's help. So the Ds, which have been explained clearly as per the American Heart Association guidelines, all these Ds has to be practiced and it should be taken care of. Otherwise, you're not going to have a successful thrombolysis of your patient. That is what is very, very important part in the management of stroke guidelines. So what are your management goals? When somebody calls you in the pre-hospital situation, that a patient is there in the house, so the treatment starts there, not at your emergency department. So you have to give the recommendations or the treatment plan where it's been activated to you. And once the EMS has been dispatched, that is the point of care between the emergency department and the pre-hospital setup. The patient should be delivered to the right hospital at the right hands. Otherwise, if he is delivered to somebody else, then he is not going to get the care where the thrombolysis has to happen, which will never happen. So this is what is the guidelines which the American Neurological Society has given to the American Heart Association, which has been followed all over the country, and it's been successful over the years of time. And recently we had a 2015 guidelines regarding the updates of all the cardiac arrest or giving the treatment in various arrhythmias or stroke, everything. But there was nothing mentioned much about the stroke management, so we are still following the same 2010 guidelines. So I'll just go by an example. So a EMS was activated for 55 years old, having sudden weakness of right upper hand and lower limbs with slurring of speech, half an hour duration. So what are the things as an emergency physician he has to take care of? He has to take care of by noting down from where the hospital, where the call has come with correct name, age, and the address, clear phone number, and where is the situation. And next important thing is your GCS, Glasgow Coma Scale. Otherwise, the patient can become unconscious there, and you cannot bring him in a safe place. And you have to tell them to put the patient in left lateral position if the patient is unconscious in the house, which is very important. And give them reassurance, because in our country there are many situations and many types of treatments I need not elaborate to you, apart from thrombolysis. And the EMS was dispatched within 5 minutes, and 20 minutes the patient reached, the ambulance reached to the hospital place, that is a home. So on arrival, you have seen the patient like this. So then what are you supposed to do? You have to take a brief history, look into the airway, breathing, circulation. And many a times there is an urgency that you have to treat the hypertension part, wherein I clearly tell all the residents and the ambulance staff not to give any antihypertensives, which invariably, I don't know why, they start giving nifedipine, or then they'll say, sir, I have given nifedipine, sir, is it okay? I'll say, why you have given that? So that is what is happening. So we are changing the trend. We are giving them the sheet, what they are supposed to follow at the house, in the pre-hospital situation. And if the patient is airway compromised, we ask them to intubate the patient. If they are unable to intubate the patient, at least use the gadgets like laryngeal mask airway or the double tube, which can be easily put in, and the patient can be safely transported to the nearest hospital where a neuro team, that is the stroke team, is available. So when you shift the patient into the ambulance service, that is the EMS, you have to activate or notify the center where you're going to receive this patient, which is the receiving hospital, so that the stroke team is already been activated and they're going to get ready with the modules what they have to follow in the hospital. So go in along with this, you should also go in with the fibrinolytic checklist in the ambulance service itself, so that you know that this patient can undergo the thrombolysis or not. So I need not tell this again. This is the Cincinnati pre-hospital stroke scale, which we give them to follow in the EMS setup and score them, and also we train them in the NIHS scoring, and also tell them that whether the patient is suitable to be taken up for thrombolysis or not. So at the time the patient is being picked up from the EMS service, we calculate it as a 0 point. And from there on, we calculate them, and if the patient's saturation is at any time less than 94%, we ask them to give the supplemental oxygen to them. So in the hospital, what you're supposed to do, so you have to collect the samples immediately, you have already activated the stroke team, so the stroke team will arrive in the emergency department. Along with them, the neurologist will be ordering for the neuroimaging, and the patient will be shifted accordingly where the patient has to go and what are the things to be done. And many a times, if there can be changes in the cardiovascular system with the the stroke, but don't delay in shifting the patients for the neuroimaging with these patients. So management of hypertension only if the blood pressure is more than 185 by 110 millimeters of mercury, and the preferred antihypertensives, as all of us are aware, it is labetalol and nicardipine, or if it is very, very high, you can go for sodium nitroprusside. So during the RTPA, that is when you are thrombolizing the patient, again the guidelines is there whenever the patient goes in for higher antihypertensives. So the hypertensive state, that is if the patient blood pressure is more than 180 to 230 millimeters of mercury, or it is crossing 105, then only again your antihypertensives comes into role. And here again the clear-cut antihypertensive of choice is labetalol, which each one of us follow. So Altipase, that's what the drug most of the hospitals are using. And as one of our colleagues said, in NIMHANS in Bangalore, they are giving it at free of cost, and nowadays we have a lot of patients who are utilizing them. So then what you are supposed to do? So what we do in our emergency department, we assess and manage the airway breathing and circulation, monitor and stabilize the patient. So with the circulation symptoms, take care of him, keep the gadgets, everything ready. First, check your equipments before shifting the patient to the CT room or the MRI room, because when you arrive into the radiology department, you may be unable to find a laryngoscope or endotracheal tube in that department. So always we carry all these gadgets along with the patient when we are shifting the patient to the MRI or the radiological services. So circulation, you connect the patient to at least 2 large bore IV cannulas, 18 or 16 gauge implants with the IV fluids, and if required, the patient to be inotropic, and check for the CBG so that we can avoid any stroke mimics or anything else. So how it has been activated? These are the people whom we activate in our emergency department. Duty neuro, the CT technician are on call, the radiologist, the central lab people, so that we get the reports within 30 minutes to 40 minutes time, the pharmacist, so that the actylase should not be delayed. Once you activate, the actylase should also come to the emergency department, and then inform to the cath lab people also, so that if a patient is requiring the mechanical thrombolysis, you can shift the patient directly from the MRI room to the cath lab, so that the patient can have the facility. So what is the immediate assessment by the neurophysician? The neurophysician reassesses the patient, and he will order what scan is required for this patient. And then in the neuroimaging room, with the ABC kit, you're going to see, and then only if a patient is uncooperative or restless, only then we are going to sedate them, and if required, we tube them. What next? Next is you're deciding whether the patient is in ischemic stroke or in hemorrhagic stroke. The patient is in non-hemorrhagic stroke, and you still feel that this patient, already a lot of debate is going on, and in the morning when I was hearing to the sessions, a lot of people were suggesting that they have to undergo the thrombolysis. If it is in hemorrhagic stroke, take the help of the neurosurgeon, that's what we do. This is the time guidelines which I have set in my emergency department, and believe me, it is going on in the right track. Past 3 years, we have done nearly 70 thrombolysis, including both IV as well as mechanical thrombolysis, thanks to our neurological colleagues, Dr. Vikram. And this is what is the door to needle times which we have been achieved. The lowest time was 25 minutes, including the patient was shifted to the radiology, got the CT MRI done, and the thrombolysis was started at 26th minute of the patient. The highest time was 90 minutes. That's mainly because, as my earlier sir had explained, it's mainly because of the financial reasons. That was the late one, the 90 minutes one. But average time in these 70 patients, we saw it was at 63.45 minutes. So scope for improvement, what are the scopes? Most important is giving the guidelines and community level training. If you don't train the people at the community level, they will not know what stroke is. They will think that there is a treatment for myocardial infarction, there is a treatment for everything else. But when it comes to stroke, they are still in dark, because whenever we go for first aid classes to various organizations or software companies, they'll say, stroke, okay, we go for the, what is there? We have to go for physiotherapy or massage or something. That is the way the software colleagues are saying. So we tell them, no, there is a treatment for stroke also. Please go through the guidelines, and we give them the copies there and come. So what are the learning points? It's again shown in the recent guidelines in 2015 stroke that a lot of patients were being utilized and came very, they showed an improved benefits by using Alteplase, which reduces the downstream microvascular thrombosis. Endovascular thrombectomy is also an adjuvant along with your regular thrombolysis, where evidence has spoken a lot. Thrombectomy for acute ischemic stroke, again, it was published in JAMA, wherein you can see that it is also beneficial and which has been continuously been utilized. So neurothrombectomy trials results, stroke systems, not just device, make the difference. So there are n number of studies which are still showing that thrombolysis and thrombectomies are the line of management. This is what you are supposed to do, I am supposed to do, everybody are supposed to do, community training. Only when we train them that there's a treatment for stroke, then only the patients will be benefited. So with this, thank you very much for giving an opportunity.
Now it's so patient,
Yes,
the
sir.
pre-hospital scenario, it is always debatable. To scoop and run is one approach, or you get the patient and like if the patient saturations are going down, definitely we intubate at that point and then we shift. Otherwise, if the patient is maintaining saturations, better to get the patient to the hospital and properly sedate, paralyze and ventilate, and intubate, that is better. And mobile CT scanner, will it help in reducing the time for thrombolysis? Because many corporate hospitals now they're trying to invest in mobile stroke units, mobile CT scanner. I think that will improve thrombolysis. We can thrombolyze more patients, I think.
Yeah, surely.
A couple more important people that I feel should be here on the podium as chairpersons. Sure, connector. Do you have the connector for that? Can you give it a flash drive? You want it on? Yeah, you're right. Yeah, you can call him. Yeah. I would like to invite Dr. Fawad Abdullah onto the podium, please. Dr. Abdullah, he is visiting us all the way from Cairo, Egypt, and he's a professor of neurology. He's a director of neurovascular unit. He's a division of neurology in Cairo University. He did his medical education from Cairo University. He did his fellowship in cerebrovascular unit of neurology in Oslo University, Norway. He did his fellowship also in neurovascular lab in University of Gießen, Germany. He also did a fellowship again in the Methodist Institute in Houston, United States. And he was a visiting professor at University of Minnesota, United States, and he was a visiting professor at Neuroscience Center in Anglia, Ruskin, United Kingdom. And Dr. Fawad Abdullah he's an authority in neurovascular or cerebrovascular diseases. So I would request him to chair this session as well. The other person I would like to invite onto the podium also to chair the session is Professor Manimala Rao. She's a former head of the Department of Anesthesia and Critical Care, Nizam's Institute of Medical Sciences, and a former dean of Nizam's Institute of Medical Sciences, and currently she's the chief intensivist of Yashoda Hospitals. Please welcome the two chairpersons. And from the South Carolina he's the medical director of the South Carolina Stroke Institute in Grand Strand Medical Center. He did his vascular neurology fellowship from UCLA, and we all already know UCLA is a place that generates very good clinical trials, and also that's the place from where Dr. Jeffrey Saver and people like Dr. David Libeskind are from. He is a trainee of these two faculty members. He did his residency from University of Chicago Medical Center, his internal medicine residency from State University, New York, Downstate Medical Center. He did his medical education from South Carolina. He has a very good collection of awards, and one of them is the White House Fellowship in 2015 to 16. He was the finalist, and this is quite an honor. They identify 2 to 3 individuals, I believe, right, who have exceptional qualities and exceptional achievements, who represent Indian community. So it's a credit. He's making us all proud. He's also active in the American Association of Physicians of Indian Origin, and he has also received several awards like the Legacy Life Award in the South Carolina. So without any ado, I will like to request Dr. Anil Yelapragada to talk to us about the US experiences of how acute stroke care is handled. It will be a nice extension after presenting how emergency stroke care services in India are provided. And we all know whatever happens in the West not necessarily can be applied to our region. So it has to be either modified or has to be changed in certain ways that those guidelines can still be applied. So Dr. Anil Yelapragada, please.
Thank you again for that wonderful introduction. I'm really proud to be here. నాకు చాలా సంతోషంగా ఉంది మీరందరితో ఉండడానికి. I speak a little Telugu. My parents are from this area, but I grew up in the States. And as one of the initial speakers was saying about how common stroke is around this area, one of the reasons I got into stroke is that in 1969, my grandmother suffered a severe right hemispheric stroke not too far from this hotel. And she had to live the next 25 years of her life with a severe hemiplegia and significant trouble with speaking as well. So this is kind of a tribute to her as well. I'm really glad to be here. So today, Nabil had asked me to talk about the state-of-the-art acute stroke management and share my experience in the United States and in South Carolina. And what I've been watching throughout this day is just a tremendous amount of similarity actually between how we're managing things and how India is trending in the right direction as far as acute stroke management, and especially the last speaker really emphasized a lot of similar points as to what exactly we are doing as well. And I'm just going to highlight some of those things. Before I begin, I just want to disclose I speak for Genentech, which is a producer of TPA Alteplase, and also for Medtronic for the implantable loop recorder, which is how I heard about this from one of the other speakers who's here as well. The objectives of this talk will be essentially to discuss a few models of acute stroke systems of care in the US that are currently being implemented. And it's a growing process now with all the endovascular trials and the growth of stroke systems and hospital corporations trying to, and also stroke centers trying to get a piece of the pie and kind of stabilize themselves inside their respective towns and cities and states. You're seeing this resurgence of insurgence of development of stroke systems and referral partnerships with EMS and state systems. I also want to just review upon some of the American Heart Association Target Stroke national recommendations for best practices in acute stroke care, and finally review the development of an actual primary stroke center that I developed utilizing these best practices to show how it can be effective in your systems as well and really improve the care in this region and beyond. So the basic philosophy has kind of been highlighted in some of the previous acute stroke talks today and questions. A lot of the questions actually highlighted and kind of set the stage for this particular talk, I feel. The first step really starts with patient knowledge, recognizing the stroke symptoms in oneself or in a family member or someone who's nearby to kind of begin this process of the chain of survival. And then in America, we have a very good 911 system where it's an emergency dial. You dial a number and it automatically connects you to a dispatcher who can then connect you with the EMS system, which is our ambulance system that will then triage you appropriately to the nearest capable ER resulting in evaluation by the ER physician, as the previous speaker said, as well as a stroke team transferring you to a stroke unit. So this is kind of like the basic outlay. And this is just highlighting symptoms, 911, EMS, primary stroke center, imaging, and then hopefully the thrombolytic therapy if the patient is a candidate. So as the previous speaker said, again, it's, you know, acute stroke care is a complete team effort. It's a complete multidisciplinary, collaborative effort by a number of different individuals with a number of different backgrounds who all play an instrumental role in developing the best quality care for the patient. And it involves a number of different ancillary staff and physician groups and nursing staff and organization. So, you know, this diagram shows one possible scenario of how this team can come together to implement the best level of care, involving the emergency physician who's kind of driving this, but sometimes it may be the stroke neurologist or the internist or whoever may be in that position. Some, as the next speaker may highlight, telestroke can also be a possibility as a way to kind of be a part of this circle. And of course, your radiology, your pharmacist, your stroke neurologist, your stroke coordinator, as I'll highlight, will play a big role. I don't know if you guys have stroke coordinators in your hospital, but they're an invaluable asset to really building a good stroke center and a stroke system, as well as your emergency nurses and EMS personnel. Everyone is critical. It's a complete team effort. You know, some of the early support of acute stroke care, we always talk about IVTPA, but just to kind of highlight that, you know, these measures have also contributed to better outcomes in stroke, longer, you know, and in addition to the early IVTPA, treating the hypoxia, maintaining normothermia, avoiding hyperglycemia, maintaining collaterals, as one of the other speakers this morning asked, you know, about that, and of course initiating DVT prophylaxis appropriately. The American Heart Association really has taken an effort to bring hospitals in America into a system of what they call Get With The Guidelines, which is a set of core measures that, if implemented, can result in best practice outcomes for patients and improve longevity. And these hospitals are awarded different kind of stars or different kind of levels, whether it's a bronze level or silver level or gold level. That kind of gives an indication as to the quality of this hospital. I'm not sure if you guys have that here, but it's a good method to have, kind of motivate the administrators, motivate the team, the stroke team, to identify themselves with a certain level of quality in their hospital. And also it can be used a marker and kind of a way to kind of identify ambulances and also the local community that this center is a better center than the other center. And it's kind of a capitalistic way, I guess you could say, to kind of raise your level of quality at the same time, you know, providing that incentive to do that. There was some questions this morning about, you know, how do we, you know, about primary stroke centers versus comprehensive stroke centers. And this is a really hot topic right now, and how this is going to be organized in the United States from a U.S. experience, because, you know, there are stroke-ready hospitals. There are hospitals that can, you know, that are close enough, especially in the rural areas, that can initially see the patient, maybe need some guidance from a primary stroke center or a telemedicine facility, or you know, maybe a comprehensive stroke center, or they just have just enough to kind of stabilize the patient, give the TPA and what we call DRIP, SHIP, and then potentially GRIP if it's endovascular clot retrieval. DRIP meaning start the IV TPA drip, ship with an ambulance or helicopter to the next or the nearest facility so they can get a high level of care. This diagram just kind of illustrates that there are these different levels of hospitals that are developing, and now each kind of city and state is kind of working to develop what are the requirements for an EMS even to, should there be a map saying, well, if the patient has these particular stroke symptoms and qualities, they shouldn't be bypassing, in certain cases, a primary stroke center, because that would only delay endovascular care, which is really what this patient needs with the large vessel occlusion, where they can also receive IV TPA. That's one of the hot topics that's going on right now from a USA standpoint. So, you know, I talked about the basic primary stroke center setup with recognizing symptoms, calling 911, activating EMS, sending to a primary stroke center, and then imaging. But now the next level, as we were just alluding to, is the endovascular care, the higher level neurocritical care management, the center that maybe has the higher level multimodal imaging that may be needed. And so that's kind of where the rest of that diagram is kind of taking over on those smaller pictures. Target Stroke was really a national quality initiative that was generated in 2010 by the American Heart Association to kind of couple themselves with the Get With The Guidelines criteria to improve care in patients. And the goal of this whole target stroke was to basically decrease the door to needle times using certain methods. A lot of these methods were actually described by the last speaker for the most part. There were a few that were kind of in the target stroke that weren't described, but again, that would kind of, I think, improve the door to needle times in all of your hospitals, even if you try to implement even a few of those if you're not already. And so essentially, when they first started this, they realized that the goal was to make sure that they wanted everyone in the country, every hospital that provides stroke care, to have a door to needle time less than 60 minutes. That's the national goal. They realized that only 30% of the hospitals participating were meeting this goal. And they really put an emphasis on door to needle times because the studies really showed that early treatment results in the best recovery, and that's true for endovascular treatment as well. And the logic is very simple. It's while your collaterals, like we were talking about earlier, are still robust and kind of giving you that ancillary that support. In addition, the neurons that you haven't lost, every minute that a stroke occurs, you're losing 2 million neurons. Your brain has 100 million neurons. All of our brains have 100 million neurons, essentially more neurons than stars in the Milky Way galaxy. But during a stroke, every minute since it starts, you start to lose 2 million neurons up until a certain time. That's an average kind of calculation. So we want to save as many of those neurons. That means every minute needs to be saved. And so that's why we're trying to build a very efficient system. So after the target stroke was initiated in its first in the first round in 2010, about 1,200 hospitals were signed up for to get this going, and it was the goal was to get 50% or more eligible patients treated within 60 minutes, and they saw that they were able to have a 15-minute improvement in a relatively short period of time, from 74 minutes average in the country to 59 minutes for all the Get With The Guideline hospitals. And this resulted in an increase from less than 30% of the patients receiving IVTPA within 60 minutes, all the way up to 50%. And this resulted in improved outcomes, lower in-hospital mortality, and reduced long-term disability, and ultimately better, lowering the economic burden of stroke in the entire society. As one of the speakers, the rehab expert was talking about earlier from Mumbai, it's so much of the disability of stroke is carried over even if the patient receives IVTPA. And so one of the goals of this whole thing is to kind of reduce all of these things so that these patients can go back to a functional outcome and not be a burden to their families themselves, to the community, and save work hours and just really improve the community. I think there's a huge aspect of that as well that may be able to be argued for the benefit of providing these patients with IVTPA instead of having them to negotiate a price to get treated. So what exactly was Target Stroke saying? Target Stroke basically outlined 11 strategies. I put 10 because I combined one of them into 2 because they're the same thing, essentially. But it starts with EMS pre-notification. That really, in my experience, really stems starting at UCLA with Dr. Jeffrey Saver, is I got a first-hand exposure to pre-hospital notification with the FastMag trial. And we saw, just from the information that we were getting from the ambulances all across Los Angeles County and beyond, that you're able to determine with fair certainty whether this patient is having a hemorrhage or an ischemic stroke. There's a lot of features and a lot of patterns that you can recognize just if you can have a communication established with the EMS before they arrive. You can kind of ask these questions and they kind of know what to recognize, and there are some clues that you can have. Another thing is you can actually help with gather a lot of information for the patient, just like the previous speaker was saying, including exclusion-inclusion criteria before the patient even arrives. And I'll go over an example of this. Establishing a rapid triage protocol and stroke team notification. The previous speaker also mentioned that, about how his entire team was notified before the patient arrived with good pre-hospital notification, so everyone was ready. That comes down to single cell activation. Transferring directly to CT scan, not taking the patient to the ER room to get a family history and get a chest x-ray and get an EKG and kind of, do your exam there, then decide when to take the patient to CT. If you have a suspicion for a stroke, getting that patient directly into the CT scan saves about a good 5 to 10 minutes. It's 20 million neurons. That's a good chance, it's a better chance of recovery. And you'll see how all this time adds up. Rapid acquisition and interpretation of brain imaging, having a good relationship with your radiology department and your radiology technicians, understanding that stroke is a serious emergency, that the brain is being injured irreversibly, and so there should be no delay, and the stroke should get priority. This is another thing I picked up at UCLA. Rapid lab testing. the labs that I would need would never really delay unless I had a history of anticoagulation. I don't really wait for lab results. And that's something else that the American Heart Association has kind of embraced, and a lot of literature is embracing. There are certain people look for, I would, if I suspect that the patient may have renal disease or history, or if they tell me, they have a problem with dye, those kind of things, or, we take all that information as the best we can get, but but we have methods with the POC getting creatinine or getting a rapid anticoagulation results with INR for patients who are taking Coumadin. Rapid access and administration of IV TPA. People say a lot of hospitals in the U.S. are stocking the ER with the IV TPA so they can mix it right there in the CT scanner or in the ER and give it to the patient. We had a very good relationship with our pharmacy, who was also on our activation system. And so they were able to rush down to the CT scanner as soon as we call them, say, hey, this is a good candidate. They would mix the TPA ready to go. And in the U.S., the company Genentech, which produces this drug, will reimburse you if you mix it and don't use it. So it's kind of like there's no loss in the drug. They'll reimburse you. And a lot of the times, the TPA the alteplase is saved to use in catheters to essentially, for catheters that get clotted. And so they save some of the TPA, and they save money on that as well. And of course, developing the team-based approach and the prompt data feedback. The key time intervals were actually stated in the last presentation. So I'm going to skip over this, but this just kind of breaks down everything. Everything is broken down into efficiency, and the team is aware, the coordinator keeps track of this, and we review every case. It's very important to review every case as you're treating these patients so you can improve. You can't improve unless you review the cases and see where the pitfalls are, where are the mistakes happening where we can improve and get faster or more efficient, or if there's a mistake made, or maybe something good was done and you want to highlight and reward your team members. So I'm glad I'm at this stage, because I wanted to go through those kind of quickly, because a lot of that was already kind of discussed. This is an example of what I did after I left UCLA and moved to Myrtle Beach, and an example of a case. So it'll put things more into perspective of how we're managing patients right now. So this is a map of the United States, and like one of the other physicians was mentioning earlier with the map of India and the South Asia and the stroke density, when I was a clinical instructor after I finished my fellowship at UCLA, I was researching what part of the country had the most strokes. I wanted to go to a place where I could have a direct impact and kind of work in an area that's rich in stroke. So when I started to look at this map of the United States, I realized that there was it was a temperature map. So you're looking at the higher level purple areas are more stroke than other parts of the country. So there's a great inequality. Most of the dark purple states are in the southern states. North Carolina, South Carolina, Georgia, North Florida, Louisiana, Mississippi, Texas. That area of the country is known as the stroke belt. Carolina, South Carolina, and Georgia. I happened to grow up in South Carolina. My dad went to Kakatiya Medical School, came to the United States, studied pulmonary critical care in the Medical University of South Carolina, and he settled down there. And we've been there for 30 years. But I moved around. I moved to New York, Chicago, Los Angeles. So I was like, oh, great, South Carolina. I didn't even know that it was in the stroke buckle. Maybe this is a possibility. So I started to do a little bit more research. Where in this area are the most strokes occurring? And what I found interestingly was where that arrow is pointing, that little black area that just got highlighted, that is the highest level of strokes in the country. It's actually the true stroke buckle within the stroke buckle of the belt. And that is on the coastal strip of North Carolina, South Carolina, where it's very rich in, where people have a lot of risk factors, kind of like India, kind of like Hyderabad. People have a very bad diet. They eat a lot of carbohydrates, a lot of fried food. They love fried food. They have like their own kind of budgies and what else there. They have fried fish. They like calabash, fried fish. Eat a lot of fried fish. They fry chicken. They fry everything actually. They fry Oreo cookies. They fry butter. They fry their salads. They love fried food. French fries. They eat a lot of fried food. It's also the tobacco country. So people start smoking at a very young age, at the age of 15, just like we were saying in the Northwest India, I believe. Now, when you combine that with the next level, sorry, very quickly, okay. So anyways, highest level of stroke. So the next step is that if you look at the region where the strokes were occurring, it's there was actually no stroke center. So I moved there to build a stroke center, and which is interesting. The most level of strokes in the country, no stroke center. This was all being supplied by telemedicine. So we started a campaign to build an efficient system. starting with community EMS education is number one. We went on to the community educated stroke coordinator, built a stroke committee, vascular neurology team, built ER system support, door-to-needle task force, and building bridges. We went on into the community. We went to nursing homes, churches. We went into kindergartens, high schools. We motivated the college students to get involved, to come out and teach with us. We taught everybody. We went for 2 months just teaching in the malls and healthcare, in health classes, health services. We incorporated into the curriculum of the schools. Everyone's going to know about stroke so they can get activated. If they recognize it, they can call 911. Next step is to get 911 ready, and we educated 911 and EMS. We went out to the EMS houses. We met with all the EMS guys, the chiefs. We invited the chiefs into our hospital. We had meetings there. We developed a stroke team within our hospital, a multidisciplinary team, just like the last speaker. The central person with this is the stroke coordinator, who's a nurse who's in charge. Very critical to have a very, very empowered, motivated, champion stroke nurse. Then we implemented the stroke team, stroke best practices with some of our best practice methods that we added on, including the stroke alert page. This is an example of a page that came out. I'm actually going to play it, and I'm going to go fast because I think I'm running out of time. So this is an example of a patient who's a 47-year-old female. She was actually a grandmother at 47. And at 12:35, she was playing with her, this is in February of 2014, was playing with her granddaughter when she suddenly collapsed. After she collapsed, her granddaughter recognized that she was having a stroke, told the grandfather called 911, and they called, and 911 came. This is an EMS call that actually came out. I'm going to play this for you guys so you can hear how we interact with EMS. One second. Where's the volume here?
Notifying you of a stroke alert for medic 23, 47-year-old female patient. Onset of symptoms less than 10 minutes, right-sided deficit. ETA will probably be about 15 minutes.
Nothing further, arrival good out.
So from the first call, I got this.
Grand Serenity, medic 23 over 800.
This is Grand Strand, go ahead.
Grand Serenity, medic 23 coming in with that stroke alert. This is a 47-year-old female. This is sudden onset. From now, we're looking at about 20 minutes of onset of aphasia, total right-sided paralysis, and the right-sided facial droop. She has vitals of 183 over 124, 88 heart rate, sinus rhythm on the monitor, respirations are at 20. She was sat 98 on room air. We have a blood sugar of 83. She is on oxygen. IV access has been established. We're going to be there in about 10 minutes. Any further questions, orders?
This is Dr. Yellow Pragada. I just had one question. Are the eyes deviated at all?
This is what Dr.
Affirmative. She's not able to look to the right.
Not able to look to her right?
Also, for pupil dilation, she had previous trauma of the right side, so her right eye.
So basically, I'm going to skip through quickly here. If you just by that information, I'm able to get that the patient has aphasia, left gaze preference, right-sided weakness, heart rate, and all the vital signs and the blood sugar, and establish some level of understanding of what the patient has. And this all happened, remember the patient's symptoms started at 12:35, and they're en route already, and I'm getting all this information. So the patient arrives at 13:05, at 1:05 p.m., and taken straight to CT scan. She had an NIH of 19. Her blood pressure was high, which I already knew, so I had the blood pressure medication waiting for when she came in. We rechecked it. We treated her blood pressure. She has significant left MCA syndrome, so if you know that if she survives this, it's actually worse than death. It's very severe, NIH of 19, very high score. I'm able to localize the lesion just based on all the information given, the eye fields, the aphasia, the weakness, and also I'm able to localize the arterial distribution relatively. Is it an internal carotid or MCA? Even before the patient gets there, and then I do my exam to confirm. So when I get the CT scan, I'm kind of looking in that area, and I see here there's an MCA sign, a small MCA sign there. By 13:16, I call for the TPA. The blood pressure is controlled by then because we're doing everything in concert. By 13:20, we treat the patient with IV TPA, and NIH has improved from 19 to 5. She improves right on the table. It's not uncommon to see that. in your endovascular cases or your IVTP when you recanalize very quickly. And her gaze preference went away, her aphasia improved. She was left with some minor right-sided hemiplegia at that time. So you can see here that the symptoms started at 12:35, and she received IVTPA within 13:20. So she was treated within 15 minutes of arrival, within 1 hour of the time of onset of her symptoms. We were able to replicate this over and over again in a series of patients, treated over, I think, 160 patients over 20 months. We published this in 6 months, our system of care and what we did. And I'll go into that in a second. But even though we treated her so fast, you can see that she still had a small stroke on DWI when reevaluated. And the reason for that is this clot was sitting right here, and it was covering these perforating vessels, lenticulostriate, and it forms what's called a macoon. Instead of a lacoon with one vessel, it's like a macoon. We call it macoon. And so we saved this entire hemisphere from stroking out in this lady just by treating her very, very quickly and recanalizing. So it's very important to try to treat as fast as possible. This is the same lady. She was able to come into the hospital. We do a lot of feedback in the hospital. We would bring the patients in, share their story. Everybody in the hospital who's involved with the care, anyone who's interested in learning about stroke, we would teach them also to get people excited. In addition to forming heart stroke walks with our heart stroke survivors to come in and we walk and we show the community that we're doing stuff. Eventually our median door-to-needle time for that 6-month period was 26.5 minutes, which was the fastest in North America. And it was actually the third fastest in the world at the time. Helsinki, Finland, of course, is number 1, 20 minutes, really quick. Germany, and then Myrtle Beach was actually at that time number 3. So this is just showing the best outcomes. Our stroke alerts went up because more patients knew about it. We were treating more patients compared to previous year by 400% or 500%. Our outcomes improved significantly. Our hemorrhage went down because we're treating patients so early. There wasn't enough injured tissue that would bleed. Mortality went down. Our door-to-needle times completely improved. Our entire hospital was excited. This is a copy of our abstract. This is my stroke team. We were awarded the highest level Heart Association Award for Gold Elite Honor Roll, Target Roll, Elite Plus for all our time was below there. And I was recently in Mount Everest a week ago, so hiking. I just wanted to share those pictures with you. Thank you very much. Sorry to take over. Okay.
Appreciate that. I know we are all passionate about stroke. I think we all can keep talking, but in the interest of all the delegates and audience here, we'll move on. Our next speaker is Dr. Dheeraj Khurana, who has traveled all the way from Chandigarh. He is the president of the Indian Stroke Association. He is in charge of the stroke program of the PGI Institute Chandigarh. He is a professor in Department of Neurology, and he also has a lot of credentials and awards and honors. He has published more than 70 national and international papers. His personal interest is stroke, of course, and also he shows interest in neurosonology. He has served as a PI of multiple international clinical trials. He also received a Practicing Physician Quality Award by the AAN, and he also received the AAN International Alliance Committee Award. So without further delay, I request Dr. Dheeraj Khurana to come here and talk about strategies for the future of stroke care in India. We already talked about the burden, we already talked about the challenges, so we will like to hear from the President of the Indian Stroke Association the strategies.
First of all, it's indeed an honor to be here, and thank you, Nabil, for inviting me to this wonderful meeting. It's in fact a very unique meeting. I believe this is my first attendance to a meeting where organizers from the US have done the organization in collaboration with physicians in India. And I do believe this is a very good initiative, and it's very encouraging, and should open up a lot of vistas for collaboration, number one, and hopefully we should look for much better care. And Dr. Qureshi, it's a great, we welcome you here, and it's absolutely a big honor. Okay, so he's put me into a tight spot by asking me to speak about the future of stroke. Did it start? Well, I'm sure since morning a lot of talks have taken place talking about the burden, the excessive burden that India is carrying with stroke, not only India but developing countries. So I'm not going to be bogging you with repeated figures that you've probably been looking. So my main purpose is going to be having an overview of the situation we have in India and the LMICs or the developing countries, and let's look at the solutions that we are already having, or maybe what we could have sometimes in the future. So my talk is going to be predictive as well as intuitive and maybe counterintuitive. So just going through the statistics, we all are aware. Do we have a pointer here? That's fine. So the global dailies that's afflicted the world. What happens with stroke is, it's surprising. In fact, it was a big shock for me too. Thank you. They seem to have ranked from number 5 in 90 to number 3. So in right and around 10 years, that's what we are looking at. The number of dailies, that's disability lost years, are increasing due to stroke. It's a second leading cause, there's no doubt in it. Now in the US, it has recently been now labeled as a 4th leading cause of death. And if you read the literature a couple of years back, it was a 3rd leading cause. So measures have been put in place in the West, bringing it down to at least one place down. That means huge numbers. And in India, the numbers are definitely increasing. In fact, in developing countries, it's believed that 10.5% deaths are due to cardiovascular disease. And this is from the Global Burden of Disease data, which was one of the highest studies and giving us a lot of insights into developing country. Now, if we compare the, basically India, which would be included, we do not have specific data for India, but if we look at the lower middle income countries and we compare it to the developed world, if we look at the dailies lost due to cerebrovascular disease from 10 years, there's an increase in India or lower middle, whereas there has been a reduction of these dailies. There's another figure which is the years of life lost. We do not have much figures from the lower middle income countries, but again there has been a reduction in the US. So what we need to do is maybe look at our Western counterparts and the developed countries and see what kind of priorities are being given to healthcare and something like a very morbid disease like stroke. If we look at the general situation, we know that the trouble is rising. In the future, it is believed that India is going to be having probably the highest burden of stroke. And it was believed by these figures from WHO that $8.7 billion have been lost due to coronary heart disease, stroke, and this is going to increase. So already projected, which I'm sure we would have exceeded by now, $54 billion. And not only that, it is this study which would actually be a big glaring thing, just published this year, which looked into the rural village in Maharashtra by Dr. Kalkonde. They found excessively increasing deaths in the rural area, which were much higher than the previously recorded or previously published data, where around 14.3% deaths were caused by stroke. And those who died had a mean age of 68. Interestingly, the women who died due to stroke were almost 48%, which is like half of the people who died due to stroke were women. And it was concluded that it was found 1 in 7 in this rural community died due to a stroke. Even in the past, it's been found that around 70% of patients who have a stroke are left with severe disability and do not have, they have unmet needs of care in stroke. So obviously we have a huge burden of stroke and something needs to be done at a priority basis, but more than words, I think action is needed. The challenges we face are the rising stroke incidence, which is very evident from a lot of registry data that we have. In fact, whatever I found in the last few years that I've been looking into these stroke scenarios, we've got a lot of registry data, a lot of state data where registries are being looked into for causes of stroke, the mortality, rehab services, etc., etc. And that's a very encouraging thing, that because it is these data which drive the policies of the administrators. Another thing is we have lost resources, both human resources as well as economic resources, the access to stroke care is one of the most important things that is lacking in our country. We have, in the acute stroke scenario, most patients cannot afford TPA, as was shown to you in the previous talks. Stroke unit care is not rampant, and I'll come to the details later on. Rehabilitation is deficient. So these three areas are, I would see stroke as a holistic care model which needs to be developed for the future in a country like ours. So what needs to be done? Of course, we need to get our act together. We not only starting, now what has happened in the recent times is a lot of newcomers, in fact, a good percentage of new neurologists have there's a rampant increase in the interest in stroke. I'm very happy with that. In fact, it's a very encouraging sign. In fact, myself, I'm a big pusher for that. I mentor so many students who go into stroke. And of course, this rising trend of neurologists going into intervention. There is no harm in it. I see no harm in it, but I would just wish that all these neurologists would actually look into the stroke scenario and also look not only to just go and treat small populations, but look at larger population interventions, which actually is going to make a whole lot of difference in our country. Which means we have systems research, which needs to be taken care of. We almost have negligible areas of systems research in our country. And I do see ample opportunities where we can work, and in fact, that's where the future lies. So first of all, let's look at stroke awareness. A number of studies, I'm not going to go into data. There's ample number of studies published. We have done one, which still is, it's still under publication. So knowledge, attitude, and practice studies, as we call them, the CAP studies. All of them tell us that a lot of people are unaware of stroke. They do not know what stroke signs are. They reach late because of that. They go to other doctors. They go, and in fact, physicians, general physicians, even they themselves are not aware of stroke symptoms. That leads to delay in access to stroke care. So what do? I believe the CAP studies, let them continue. Of course, there is a good number of people who won't, and that's how it starts. You know, the stroke career, as one goes into a stroke setup, he usually gets this first thing in his mind, let me do a CAP study. I would suggest that newcomers who are going into new systems, they can kind of avoid this and maybe go on to something more meaningful, because they're going to get the same answers. Doing a CAP study here, or maybe doing it in Punjab or in Kashmir, most of the data is going to be similar. So what do we need to do? I would look into more novel ways of starting an education, making people aware of it, and start putting efforts into looking for ways of mass communication and mass education. A countrywide awareness program is still lacking. We do not have any national, I would say, celebrity talking about stroke. We did have, in fact, I still have those videos with me many years back. Rani Mukherjee made a video for Indian Stroke Association a few years back. Never got very popular. Anupam Kher made a video in Hindi. Never got popular. So that is one area that we need to really see. How can we go to a countrywide basis for awareness? Messages specific to India need to be developed and propagated. And in this direction, something very heartening has happened. A colleague of mine who, in fact, one of our students who was a pass out, she did her stroke fellowship at Houston. She's back here in India, and she developed this. So this is the Hindi version of FAST, quite novel. In fact, and the reason why is we also conducted a survey. We have a perpetual ongoing education of FAST to all the people, all the patients who come to our OPDs, the stroke survivors, their families, and we called them a year later. None of them even knew what FAST was. So we keep on wondering, we're telling them FAST, but a year later or maybe a few months later, I'm sure most of them would forget it. So this is something which has now been recently developed. She's started her own NGO, and this is now the Bachav. Be Bazu, Chehra, Awaz, and Waqt. And in fact, I think one of the companies, the stroke companies, has taken her, bought it from her and using it for the propaganda. So things like these, of course, they need to be researched. But this is a new innovation which has come up because FAST has been the only one being used in the country. And there may be other locally available versions of FAST for education, which I'm not aware in other countries. But this, I believe, is one area which people do need to study and see the feasibility of this kind of a local language media awareness. I was looking into the strategies applied by the West. So there was this interesting paper on advertising strategies to increase the public knowledge. This is from Canada back in 2003. Of course, this is more than 10 years back. That's the time when most of these stroke systems were getting developed in the US too, and North America in general. So again, these are the things that we need to adopt still. We've had a stroke program, I think active stroke programs running since around 2001 or 2. My center, we started our program in 2001, around early 2002. So it was only, I would say, a big mushrooming has happened for stroke treating hospitals in the last 5 to 6 years. That's very heartening. But the strategies for stroke education do not have any novelty till now. And I think something of advertising needs to be done. Of course, it goes on to the ISA too. So we do have a plan which we would be instituting maybe in the next few months, trying to get a nationwide education program. EMS, we had excellent lectures preceding my talk, talking about the EMS services. We know that the EMS status is almost fragmentary. We hardly have effective EMS or emergency medical services or pre-hospital notification or whatever we may call it. So this was an interesting paper I looked into. This was basically as in the previous lecture by the emergency colleague from emergency department. This was for injured patients, and that's where actually the concept of stroke centers did arrive. It was basically from trauma centers. They also have a golden period, we have a golden period. So the concept was similar, how to give rapid access. And they looked into this interesting scenario where there actually are no emergency medical services. So how do most of the patients who land up with an accident are brought in? And what they found was, this was done in Mumbai, that most of the injured victims, they are usually rescued by a good Samaritan. They'll be carrying the patient into the hospital. Police, contrary to most people's belief, they helped in most of the cases. 90% of the cases were helped by the police. And taxi happens to be the most popular, by 40% using a taxi. An ambulance, nobody waited because there is no EMS. And this was just a few years back. And almost immediately after the rescue, there is no delay. They're taken to a hospital, not to a doctor. So that is a scenario which kind of reflected that EMS may not actually be effective. And interestingly, there is no evidence in trauma that EMS works, at least in our country. Because you need to give an evidence to the policymakers to get developing a certain service, putting in money. So what about EMS in the stroke? Well, all the data, like I'm not giving you the data figures, which I'm sure would have been elaborated in the previous talks. Again, most of the patients who arrive for a stroke come in their own vehicles. Most of them come in their own vehicles. Hardly 1 or 2 come in the ambulance, and that's been the usual observation in most of these studies of patients who reach the emergency. Currently what we have, again, as I told you, they are fragmentary. There is no trained paramedic staff manning the EMS services. There is no connectivity between the hospital and the EMS services, excepting maybe a few systems which are being developed. So pre-hospital notification, pre-hospital treatment, of course, we can't even think of it right now. Because that's what's actually started worldwide now to cut down the stroke treatment times. So EMS, of course, is one of the recommendations of the American Heart Association. Most of these things, what I'm talking of, education, EMS, they are all recommendations of the American Heart Association as class 1 evidence to be developed in stroke systems of care. And this is again 108 present all over the country. Again, 108 in every state is different. And most of them are used for propaganda of their political motives, like this one is in Punjab. So this hardly is practically used for that. Another thing, so once we go on to the next step, so EMS is one area I think which needs to be developed again on a national basis. What I have recently come to know, there's a national trauma line which is being developed by under the direct supervision of the PM, and which is a 4-digit number now, and that's a national line. So you call up, and there's, because I'm in communication with the people who are developing it. It's basically a company. So something of that sort can also be developed for stroke. but that's only if the administrators consider stroke to be important. The center designations, the hospital systems, we've had enough talk on acute stroke ready hospitals, the primary stroke centers and the comprehensive. I'm not going to go into the details of what these are, but the important part is, as Dr. Anil just showed, there is mapping of these more in countries in the West. In the US, for example, all these are mapped onto your, by GPS, onto the, maybe the vehicle or the EMS system which is carrying. These are mapped hospitals. And they know whether the patient is close to the primary stroke center, which is a center which is capable of stabilizing any care, any stroke in the acute stage, and has the capability of transferring that patient to a comprehensive, and the comprehensive is usually essentially a tertiary care hospital having all the services, including a neurosurgical staff, has all the special tests, so basically can take care of complicated strokes. So these designations, the mapping, is one thing which I believe is another another step towards probably better care of stroke patients in our country. It is in the pipeline, and I believe the ISA is taking some steps to provide the map by taking the, we would not be able to right now designate primary and comprehensive, because even the certification statuses and the definitions have not been well defined. So the ISA is currently even in the process of defining the bare minimum requirements of a stroke center, and they would not be as stringent as defined in the BSc, the Brain Attack Coalition or the AHA, but it's going to be a little step down. So once these maps are developed, I think that's one of the areas which will in the future lead on to the interfacing of this with the EMS if it develops. So at least we need this in place. So after these hospital system improvements, the EMS, we need to look into hospital systems to cut down the barriers. Interventions are needed, education is needed. So in the same step, in this direction, to reduce the time delays in the hospital, this is what we carried out in our own systems, which was which showed a very, I would say, a very, very interesting observation. After just simply educating the in-hospital staff, the paramedics, and the residents, what we observed was a gross reduction in door to CD times and door to needle times. This was the time of the intervention at around 2 years back. In fact, it was this study which got us the AN Practicing Quality Award, Practice and Precision Award. And what we found was not only the door to needle time reduced, the total number of patients, of course, increased drastically who were treated within less than 60 minutes. And in addition to that, IVD rates also improved, clearly showing that those patients were missed by the paramedics, by the residents in the hospital. And of course, the hospitals can have no comparison with the hospitals in the West, especially a tertiary care hospital like PGI. There is it's an indescribable rush in the emergency in the ER. So to even detect or pick up a stroke patient is a big challenge over there.